We are live to audience, sir.
Very good evening, one and all. Yes, I'm sure. Today we are doing very offbeat topic, but clinically highly relevant topic, that is nothing but bronchiolitis. This is Dr. Vijaykumar from Hyderabad. So it's absolutely an honor and also a pleasure, moderating this session. So before we begin, I must acknowledge Dr. Amita Nene. What a energy here. I don't know when madam sleeps, when madam work, and how she coordinates so much of academics all across the subcontinent. Academic excellence doesn't happen by accident. It requires a lot of vision, structure, and relentless effort. All these three qualities are there with Amita ma'am, and she has demonstrated that consistently for the past many years, close to a decade. Thank you so much, Dr. Amita ma'am, for the opportunity and then bringing out this rare topic through ICS to the entire pulmonologists of India. I must thank ICS for giving this opportunity, and thank you Lupin and thank you Devansh for technical support and also sponsoring the event. Without a delay, I must tell you, to my best of knowledge, this topic has not been covered in any of the pulmonology fraternity webinars. So when we were discussing, me and Dr. Amita, we thought of, doing something very highly clinical relevant but uncovered topic. Then it came to my mind that bronchiolitis has to be covered to the depth. So today we will be discussing about bronchiolitis, and no doubt which is most under recognized yet most consequential small airway obstruction in pulmonology, from transient inflammatory bronchitis to irreversible constrictive bronchiolitis obliterans. We will be covering pathology, radiology, immunology, transplantation, toxicology, and systemic diseases that causing bronchiolitis, everything. Yes, the small airway is less than 1 millimeter in diameter, which determines whether airflow is preserved or permanently lost. The difference between inflammatory and fibrotic bronchiolitis is not just academic, it is quite prognostic. And I was just thinking how to set the stage. So when I was contemplating, it just came to my idea. When we look at broadly from a drone side, probably rather than drone side, probably from few kilometers, 10 kilometers, 20 kilometers away from Earth, over India, if you see the network of roads, we have probably 1.5 lakh kilometers of national highways, nearly 1.8 lakh kilometer of state highways. That means they are all the larger highways. They are all very massive, visible, but the rural area network, that is close to around 45 lakh kilometer, this we can bring in as an analogy to small airways. And it is very important, the rural area, unless the rural area network or road network is very clear, whatever the economy that is generated in the villages cannot be translated into a good economic value. Similarly, small airways for oxygen transportation, carbon dioxide ventilation, they play a very crucial role. And without a delay, I would love to introduce my star-studded panel. Today, we have Dr. Kapil Iyer. Entire nation knows Kapil is one of the renowned transplant pulmonologists of this country. We are proud to have Dr. Kapil today. And Kapil bhai, welcome to this webinar. And I'm sure Okay, we'll be having 20-25 minutes talk on bronchiolitis obliterans syndrome with vast experience in transplant pulmonology and having trained from Manchester, UK. We are going to listen to Dr. Kapil's input on bronchiolitis. Especially, we'll be learning a lot from Kapil in related to field of transplant pulmonology. And next, we have Dr. Kranti Garg. Madam, thank you, ma'am, for honoring us and by participating in today's webinar. And Dr. Kranti Garg is a professor from Department of Pulmonary Medicine, Government Medical College, Patiala, Punjab. She has got numerous achievements: IIB Fellowship in 2025, UAPM Fellowship in 2024, and more than 70 international and national publications. We're richly honored to have your inputs today, ma'am. Thank you so much.
Thank you, sir.
And my very good friend, dearest buddy from Lucknow, Dr. Abhishek Tandon, currently working as a consultant with Department of Respiratory and Sleep Medicine, Medanta, Lucknow. Numerous achievements. Is a gold medal winner, and more importantly, very good human being, expert intervention pulmonologist, and critical case specialist as well. Love to have you, Dr. Abhishek.
Thank you so much, sir.
And next, Dr. Varuna Jethani. Very great friend, absolutely brilliant academician. So, Dr. Varuna, ICS is honored to have you, and she is currently working as an associate professor from Himalayan Institute of Medical Sciences, and looking forward for your active participation.
Thank you, sir.
Dr. Aishwarya, this is a new name, at least for me. Thank you, Dr. Aishwarya, for being with us. She has got numerous achievements. While I was going through her CV, so we are immensely proud to have you on this today's platform. And Dr. Aishwarya is from Chennai, and having worked with world-renowned transplant centers like Toronto Lung Transplant Program and Vienna Lung Transplant Program, and she is a transplant pulmonologist with other interests in intervention pulmonology and then other clinical pulmonology as well. Thank you so much, Dr. Aishwarya, for having you with us.
Thank you, sir.
Without delay, and I request Dr. Kapil to start his talk on bronchiolitis obliterans syndrome.
So just want to ask, is my slide visible to everyone?
Not yet.
Sir, your screen is visible. Please open your
Screen
slide.
visible. Okay.
I've already opened the slide. Is it visible now?
No, sir, not visible.
Now?
Yes, sir, now visible your slide.
Okay, so thank you so much, Dr. Vijaykumar, Chennamchetty. I always call you Garu. Thank you so much for that introduction, and very warm welcome to all my fellow panelists. At the outset, I would like to thank ICS, especially Dr. Rakesh Chavla sir and my favorite Dr. Amita Nene ma'am for selecting such a topic, bronchiolitis. It's a very important, relevant topic. I'm going to just set the tone by talking about very basic things about bronchiolitis obliterans syndrome, which we very famously call as BOS. And I'm going to give it only in the context of post-lung transplantation. So I'm going to be talking about an introduction. What exactly do you mean by BOS? Why exactly is it important? How have concepts changed in transplant pulmonology with regards to it? when I talk about causes, obviously it's an understatement for me to say that it is post-transplant. But however, in the post-transplant period, what are the factors which lead to causation of BOS? Very briefly, what is going to be the pathophysiology of BOS? Again, very briefly, how will a patient present to us? What will be the clinical manifestations of this disease? What are the diagnostics? And I'm going to be spending some time with regards to how exactly is spirometry so important in this disease. And of course, I will be talking about management very briefly. How exactly are we supposed to manage this, followed by a conclusion. Now, BOS is a chronic and an unfortunately progressive form of lung allograft rejection. And when it was actually found out, it was considered that almost 50% of all your survivals within 5 years will be having BOS. Now, remember, these were very early considerations of this. And I still remember I gave my exam in 2014. In my theory, I had a question about BOS. And this was the concept of BOS at that point of time. The second statement is extremely important. It is a subtype of CLAD. Now, CLAD stands for chronic lung allograft dysfunction. See, in any organ transplant, the word rejection is very important. It's a graveyard basically for patients as well as the doctors. Similarly, in lungs, you can understand rejection as something which is acute, something which can be antibody mediated, and you've got a third form which is known as chronic rejection. So chronic rejection and CLAD ultimately are synonyms. Now, when this concept of CLAD came into being, this was by Dr. Alan Glanville. CLAD is an umbrella term which has got 4 basically verticals under it. The first is BOS, which is the most common form. The second is known as RAS, restrictive allograft syndrome. Third is, of course, a mixed variety in which you've got some components of BOS, some components of RAS. And fourth, you've got an unclassifiable variant, which is very poorly understood. So I'm going to be talking only about the first vertical, which is BOS. And like I mentioned, the concept now is roughly almost 50 to 90% of survivors post-lung transplantation will develop BOS. And the median onset when it actually occurs is after your first year. So somewhere roughly in the 1.5 year mark is when your patients will actually be diagnosed as BOS. Remember, this is a median. It can be early, can be late as well. When we talk about all data which is coming in the world with regards to BOS, especially in the West, you've got data coming from North America, especially Toronto. You've got data coming from Europe. Remember, over there, the major mortality after lung transplantation is chronic rejection or CLAD. Unfortunately, this is a statement which I will take with a pinch of salt, because in our country, I still believe that it is infections in the post-transplant period, which is the #1 killer, and not chronic rejection or CLAD. So this is a statement which we must take with a pinch of salt. And what exactly do you mean by BOS? It is characterized by irreversible airflow limitation, which is caused by fibrous tissue which obstructs the small airways. Now, when I talk about causes, see, it's a very blanket statement that obviously I'm talking about BOS after lung transplantation. So obviously transplant is your causative factor. However, remember, when it was discovered, BOS was considered to be like an immunological reaction. It was almost like a reaction to the epithelium of small airways. And there were multiple insults, multiple cause factors, which unfortunately accelerated the onset or heralded the onset of BOS. Now, what exactly do I mean by multiple insults? For that, the second statement is extremely important. We have to trace the entire journey of the patient. What do I mean by that? Of course, you've got a patient who's very sick, who will be listed in a transplant center. When you get a donor call, your surgical team will be split into two. One half will go towards the donor. The second half will remain in the hospital. In the donor, you'll have a surgeon, a transplant pulmonologist who will completely evaluate the lungs, try to recruit it, and then there will obviously be a retrieval surgery, get the lungs into the implanting team, and then obviously it's the surgeon who will implant. If all goes well, the patient will have a tumultuous post-operative period of roughly about, let's say, 20-25 days. And once the patient is discharged, of course, there are certain modifications which he or she has to do. Now, what I've mentioned is roughly the entire journey of a transplant patient. Remember, at every step, whatever things you do as a team can give rise to BOS. For example, your donor selection, your ABG of the donor, the condition of the lung, whether there was contusion, whether there was infection, what is the procedure in which the donor lung was harvested, what is the ischemia time, how was the lungs transplanted, what was the incision taken to put the lungs into the recipient, how was the surgery, how long was it, did he need ECMO, did he not need ECMO, post-operative period, did he have PGD, was there infection, was there rejection. So all of these simple factors will constitute what is known as insults if done improperly, which is why we are very strict with every single step that the entire team has to do. Of course, out of all these steps, there are certain steps which are extremely crucial, which will, of course, include episodes of rejection. Remember, over here, I'm talking about two types of rejection. One is a cellular rejection, which we usually do surveillance bronchoscopies and do a biopsy. Second type is known as an antibody-mediated rejection, which is more like a genetic play between the donor and the recipient. You've got primary graft dysfunctions, you've got infections, which I said in our country, unfortunately, is the bane of transplant programs. And of course, reflux is a very important causative factor of BOS. Now, afterwards, of course, you do have the understanding that pathophysiologically, BOS is a combination of immune and non-immune mediated injury. Immune, for example, your cellular reactions, your antibody mediated reactions, non-immune, which will include infections, unfortunately, surgery, your ischemia, your PGD and reflux. What exactly it entails is there is subepithelial fibrosis and inflammation, which eventually gives rise to an OB picture, which is an obliterative bronchiolitis or a constrictive bronchiolitis. Remember, further, this worsens because there is suboptimal repair mechanisms which is seen in these patients. And of course, it causes an irreversible airway obstruction. Now, very quickly, how does a patient present clinically? Remember, in the early phases, they are absolutely asymptomatic. When the patients are discharged from the hospitals, they are on a high. The clinical team is on a high. The hospital team is on a high because obviously it's a very difficult surgery. Everyone is happy. Unfortunately, in the first 3 months also, you need very rigorous follow-up. And you need to understand that BOS can occur as early as 3 months after transplant. So even if the patient is asymptomatic, you do need to watch out for these symptoms by certain diagnostic methods, which I will explain. BOS is very insidious in onset. It is not something which will occur in a few days or weeks. It takes months altogether. It is, of course, as I mentioned, progressive, and unfortunately, it's an irreversible loss in lung function. And these patients usually present with your very typical, airway symptoms. You've got this dry cough, your progressive shortness of breath. Some of them might wheeze, and there is also, as patients describe, easy fatigability. Now, diagnostics, as I mentioned, remember, clinically, I will once again repeat, they are asymptomatic in early stages. So you have to be very conscious in ruling out or at least keeping a watch on BOS. Now, there are certain things which holistically you need to look for in the patient. There are certain things which you have to optimize. Some of them include managing the weight. You don't want your patients to put on too much of weight because remember, once the diaphragm starts going up, there will be a fall in lung function, and then it becomes really confusing to understand whether is this early BOS or is this, just increased weight which has affected the spirometry. You have to manage GRD, which is why it is absolutely compulsory that every patient before the transplant is evaluated with an OGD scopy. They will be on a list of medications after transplant, which interactions will give rise to reflux. You need to understand this. Severe cases after the transplant have also undergone fundoplication if the reflux is not controlled. You obviously need to watch for infections, which unfortunately is the bane in our country. which is why conditions such as bronchiectasis, cystic fibrosis, which might have your airways already colonized before the surgery, are at great risk. Surveillance bronchoscopies, as I mentioned, are regular bronchoscopies, which we do because you want to rule out cellular rejections. And of course, I've written DSA checks, which is nothing but donor-specific antigens, because you need to understand whether there is a genetic play between the donor and the recipient, or in other words, antibody-mediated rejections. Okay, so this is the overall thing which every patient will have to, you'll have to keep an eye on all of this. Now, spirometry is the most sensitive parameter to diagnose BOS. Remember, very, very, very important words that in the early stages, it is more of a physiological change rather than a clinical change. Hence, your spirometry might predate BOS changes before your patients even has got any CT changes, or they might have any clinical manifestations. So remember, you need to understand this. You've got the new kid on the block, which is iOS and FOT. Remember, they are under trials. Things are, becoming clear, but till now, it's not a blanket thing that you need to understand or you need to sort of replace your current spirometry practices. See, CT is the same as what we see in all our cases of bronchiolitis. You'll have air trapping, you'll have mosaic attenuation. It obviously worsens in your expiratory scans. And bronchoscopies are mostly done to rule out rejections, to rule out infections. And remember, you also have something known as lymphocytic bronchiolitis, and that is also something which you need to rule out. Otherwise, bronchoscopy per se to diagnose BOS, it's not really used. It's more of an exclusion sort of a thing. Now, I would once again like to really explain the spirometric concept of patients after lung transplantation. See, I've just given simple figures. A patient who's undergone a transplantation, let's say he's home, he comes back to you very regularly, and these are just an example of the FEV1 which they do. So 1 month, 2 month, 3 month, 4 month, and as you can see, the FEV1 slowly is increasing. Somewhere around six-ish months after transplant, we see that the FEV1 sort of stabilizes. Remember, transplantation is the only condition in this period in which you don't have something known as a predicted value. Okay, so you only have to look at FEV1 as a whole. You take the patient's two best FEV1, which in this case is the 3 month and the 4 month. You make sure that they are 21 days apart. So it's 1.4 and 1.6. You take the mean of this, which is 1.5. So the golden figure for this patient subsequently when you're following up is going to be 1.5. Why is this important? Is because your whole classification of BOS depends on this number. Remember the second column, just see the title, what I've given over there. It is percentage FEV1 of best post-transplant FEV1. So in this example, what is the best post-transplant FEV1? It's 1.5. So every spirometry, you need to calculate the current FEV1 and you have to compare it to 1.5 in this example. And based on the value which you get, you grade the patients as grade 0, which is the value is more than 90%, 0/P, which is probable BOS, which should set off alarm bells in you as a clinician, in which your FEV1 will be, let's say, 81 to 90%. And then you've got 1, 2, and 3. So 66 to 80, 50 to 65, and less than 50. Remember, these are BOS gradations. You have got different clad gradations, but of course, it's out of the purview of this topic, so I've not included that. Now, very, very, very simply, what exactly do you mean by management strategies? I've explained what is BOS, what are the clinical manifestations. Very important, I've shown you spirometry with a rough example. Unfortunately, let's say the patient is diagnosed with BOS. What are we as transplant pulmonologists or as clinicians supposed to do? So first is obviously you identify the cause and you direct your management towards that cause. Let's say you're having some active infections. Let's say you've got airway disease. Let's say you've got rejections, cellular or antibody. Let's say you've got very bad reflux. So these are all the points which you are supposed to directly manage. Second is you've got, see, this is a very controversial thing and a lot of studies are being done in this. you have to retailer your immunosuppression protocol. Now, I come from a center, and Dr. Aishwarya, who's one of our panelists, also has done her transplant fellowship from Toronto. Now, these are centers usually where the initial choice of your main immunosuppression is cyclosporin. So when your patient does have some problems, you do something known as a cyclotacro switch, in which the main agent you have to switch, and you have to start these patients on tacrolimus. There are also further things which you might do. There are some which once again give the entire jing bag of induction immunotherapy. There are some which are trying thymoglobulin. There are some which are trying rituximab. So these are all unfortunately in infancy stage. There are various trials being done with variable results. Third is something known as FAM therapy. Now, FAM starts for fluticasone, azithromycin, and montelukast. Again, out of the three, azithromycin is the thing which still has got some decent trials for the role of azithromycin as an immunomodulator in these patients. Fluticasone and montelukast, even though you can use, but it needs much more robust clinical trials. Then you've got something which is known as an ECP, which is extracorporeal photopheresis. And you've got something which is known as a TLI, which stands for total lymphoid irradiation. I'm going to give a very brief explanation. Remember, in these patients, it's the lymphocytes which are the causative cells. So these are basically therapies in which your lymphocytes are somehow damaged deliberately, and then the blood is recirculated into the patient, so that the speed of the presentation of BOS, or the rapidity with which it is increasing, somehow slows down. And lastly, of course, you always need to start considering these patients for retransplantation. So remember, this is something which has to go through a very proper channel. There will be huge MDTs which will have to discuss each and every part of the entire management protocol. So in conclusion, yes, BOS is a chronic, unfortunately progressive form of lung allograft rejection. Remember, I told it's one of the subset of CLAD. It affects more than 50% of your lung transplant survivors at the end of 5 years. We've currently got data in which this number has been crossed. It is not such a huge issue in our country because I still believe that it's infections which is the number one killer. Remember, it's always prevention which is better than cure. As I mentioned, I trace the entire journey of the patient. So every step, the entire team has to ensure that things are being done absolutely perfectly. Yes, there is rigorous monitoring of these patients which are needed. Post-transplant, as I mentioned, it's more of a physiological disease. And remember, in the early stages, they can be asymptomatic. So it becomes very, very tricky. The only way we can somehow overcome this is by rigorous monitoring. And unfortunately, you've got very, very limited treatment strategies. So you must almost pray that your patient does not get BOS. All of us should basically prevent it. And unfortunately, you don't want to land up in a situation in which the entire MDT is right now discussing about retransplant of these patients. So thank you so much, all of you all, for very patient listening.
Devansh, can you please put my intro slide? Let me have a...
Yes, sir.
So just to continue, obviously, as I mentioned before also, and I'd still mention again, that I call this person as Vijaykumar Chennamchetty Garu. That's the respect which I have for him. Not only is he a brilliant pulmonologist, but he's very, very academically oriented. He loves to teach. I am very jealous of his postgraduate students. And today, really, because this is the first time that this topic is being discussed in a webinar, you want a really dynamic moderator who will ensure that the flow is absolutely perfect. And believe me, ICS could not have asked for a better moderator. I am really happy that Dr. Vijaykumar Chennamchetty Garu is the moderator of this session. He's, of course, a senior consultant, an interventional pulmonologist in Apollo Hospital in Hyderabad. Sir, I will wait for you
Thank
to.
you. Enough. As usual, my dear friends, okay, without any doubt, okay, I can say Kapil has summarized so much the bronchiolitis obliterans syndrome that I'm sure none of you are left over with any doubts when compared to bronchiolitis obliterans syndrome. He has made BOSS talk as bold, awesome, and superb. BOS, bold, awesome, and superb. Okay, thank you, Kapil, for that very informative talk. Now, let me have all the panelists. Welcome back, all panelists. And I was told by Devansh that the number of logins today has touched and crossed close to around 1,700 are actively, listening to whatever we are going to talk tonight. And thank you all audience. And then please do let us know what else you have in your mind, the doubts, if you have any clinical cases, if you want to give, please share us. We'll be more than happy to take your questions live and get the opinions from the expert star-studded panel. Kapil Bhai, right, again, I have to come back to you. Bronchiolitis is a term where literally very loosely used by most of the pulmonologists, not only in this country, across the globe, I must tell that, because very, very rare topic and then very difficult to diagnose. So, in your experience, how do you define bronchiolitis precisely? There are some late logins as well. So for them, okay, what is its major clinico-pathological subtypes? Which forms are most relevant in adult pulmonology? Yes, I know we're not talking about transplant pulmonology alone. Broader perspective, over to you.
Thank you so much, sir, for that question. And you're absolutely right, sir, when you said that sometimes bronchiolitis is a term which is very loosely, used not only by pulmonologists but also others. So, sir, a very, very simple sort of an explanation. I would like to break the term bronchiolitis into bronchial and itis. Itis means inflammation, and bronchial, as the name suggests, is that part of the airways which is between the major bronchi and the alveoli. Now, in your introduction, sir, you yourself mentioned that there is a very size sort of a criteria for bronchioles, which is 1 to 2 millimeters. So bronchiolitis is originally supposed to have been considered to be a homogeneous, but now we all know it's a heterogeneous group of either an inflammatory or a fibrosing disorders which affects your small airways, the dimensions of which are between 1 to 2 millimeters. So this is what we'll mean basically by bronchiolitis. Now, coming to the second part of your question, yes, sir, there are certain important clinico-pathological variants of this, sir. I would just like to label a few of them. So first, sir, is constrictive or obliterative bronchiolitis. I did a presentation which is more typical only for transplant, but this terminology is not restricted to transplant, sir. It is basically a concentric extraluminal subepithelial sort of a fibrosis. In our country, I would say that this is the variant of bronchiolitis which we very commonly see after connective tissue diseases. And out of all connective tissue diseases, sir, I feel rheumatoid arthritis is the one which most commonly presents with this. The second subtype is a proliferative bronchiolitis, sir, which is instead of being extraluminal, this is an intraluminal sort of a plug variant of bronchiolitis, which is not so insidious and it is more steroid responsive, as compared to, let's say, a constrictive bronchiolitis. You've, of course, got respiratory bronchiolitis, sir. We use this term very loosely when we are talking about children, especially you've got these seasonal viral infections. But even in adults, sir, the main thing is these are because of smoking-related pigmented macrophages. And then you've got follicular bronchiolitis, which I would say is more of an extension of constrictive bronchiolitis. However, the constriction over here is because of lymphoid follicles. Again, these are seen in immunodeficiency conditions, especially common variable. And you've got something known as a DPB. DPB stands, sir, for diffuse pan bronchiolitis. It was very commonly seen in the Japanese variant. In fact, even today, the diagnostic criteria for DPB is the Japanese Ministry of Health criteria, sir. So these are some of the important clinico-pathological types of bronchiolitis. In our country, sir, honestly speaking, yes, we theoretically read about all of this, but the most commonly seen are, I would still say, constrictive bronchiolitis after CTDs, according to me. My fellow panelists may differ on this, but that is what I feel we most commonly see.
Yeah, excellent sum up, dear Kapil. So, to just summarize, okay, major clinico-pathological variants, as per Kapil, what he says is, constrictive bronchiolitis, that is bronchiolitis obliterans, is what is more common. Then, of course, there are cellular variants, fibrous variants, and then there is respiratory bronchiolitis, follicular bronchiolitis, diffuse pan bronchiolitis, proliferative bronchiolitis. We call it as a BOOP spectrum, part of BOOP spectrum. And again, with the major experience of Kapil coming from transplant. So BOS is one thing which is common that he come across. But again, for the other pulmonologists sitting across India who doesn't do transplant, so all other variants do present in the patients, and then it is our duty to understand all the complete spectrum of bronchiolitis, and then only we can diagnose and then treat accordingly. And then now I would love to call upon or take opinion from Dr. Kranti Garg.
Yes.
Ma'am, so
Yeah.
What is follicular bronchiolitis, both clinically, pathologically, and what are the various investigations that you would recommend when to suspect and how to approach for diagnosis?
Yeah, thank you, Vijay sir. So when we are talking about follicular bronchiolitis, see, as the name says, so it is a follicular thing and it is into the bronchioles. So basically there is something known as BALT, which we have been reading from our graduation days also. That is, there is a bronchial associated lymphoid tissue. So there is a hyperplasia of these follicles which have germinal centers in the walls of the bronchioles. So as the name says, it is a follicular bronchiolitis. So now, when we talk about follicular bronchiolitis, we have two forms. That is, one is the primary or the idiopathic, where we do not identify the cause of that bronchiolitis. And then we have the secondary form, which could be because of, as Dr. Kapil has already said, that we can have some CTDs like rheumatoid arthritis, we can have Sjogren's, we can have lupus. It could be associated with HIVs and it could be associated with other infections. So that is a secondary follicular bronchiolitis. So when we come to the clinical features, see, since it is a disease, as you have very well given that example of highways and the rural areas, so we have the small peripheral airways which are involved, that is the bronchiolitis. So what is happening is that patients may be having cough, shortness of breath, and it what we see is usually progressive. So when we come to the investigations, if we talk about follicular bronchiolitis in specific, chest X-ray may not give us any lead, or it may show us any simple hyperinflation, some reticulations or reticulonodular shadows, or maybe because of the underlying disease like CTD or RA, we can have some features of that underlying disease itself. So when we come to the CT scans, so HRCTs are quite helpful in our patients, because here we can see the tree in bud opacities. There could be mosaic attenuation as well, and there could be small central lobular nodules. One important point which I like to focus, the classical appearance of cotton in bud appearance. So what is cotton in bud appearance in HRCTs is basically lymphoid follicles. They are concentrated in the interstitium adjacent to the bronchioles. So as we move away from the bronchioles, that is away from the interstitium which is away from the bronchioles, there will be lesser of lymphoid follicles. So that is one of the classical pictures. Mosaic attenuation I have already told. So when we talk about the pathology, that is the histopathology, suppose we take a sample for a surgical lung biopsy, obviously we will see the lymphoid follicles. Again, these follicles will be predominantly in the interlobular septa. So as we go to the alveolar septa, there will be sparse of the follicles in the alveolar septa, and it will be opposite to LIP. One important thing which I like to tell you here is that we have to differentiate since it is a benign condition, we have to be careful and we should try to use some IHCs to rule out malignancies in these patients as well. So clinical, we go by clinical picture, we go by radiological picture, we go by pathological picture, and accordingly, we decide what treatment the patient should receive. If we talk about the CTD associated follicular bronchiolitis, obviously the treatment of the underlying disease. Yeah.
Sir,
You are not audible.
See, this is the first time I learned the terminology of cotton and bud appearance. Okay, is this same or similar to tree in bud appearance?
No, sir, it is not same. Tree in bud appearance is a classical appearance which we usually see on CTs, but in cotton and bud,
Bronchiolitis is manifested as a tree in bud appearance.
it
Right.
may manifest as tree in bud, but in cotton and bud, what I want to highlight is basically the I am talking about the lymphoid follicles which are concentrated in the interstitium, which is adjacent to the bronchioles. So as
Right.
we move in the interstitium away from the bronchioles, there is lesser of that fluffiness
Super.
or the concentration of the follicles.
Thank you so much.
Yeah.
So now I ask Abhishek to take this question. Dr. Abhishek Tandon. Okay.
Yes, sir.
What systemic? Yes, Dr. Kranti has mentioned very clearly about primary and secondary forms of follicular bronchitis. Now, with that information, how do you want to manage follicular bronchiolitis in your clinical practice? And one quick comment. Okay, Dr. Kranti also commented on the role of surgical lung biopsy. Is there any way, as you are an interventional pulmonologist, is there any way that, okay, sometimes a cryo lung biopsy is good enough to diagnose follicular bronchiolitis, or you need a surgical biopsy alone, and then how to treat it?
So, sir, follicular bronchiolitis is something which is secondarily, primarily rather than idiopathic. So there are common associations associated with the follicular bronchiolitis, like an autoimmune disease, most commonly rheumatoid arthritis, Sjogren syndrome, or SLE. If this is the case, we would go in with an immunosuppression, steroids plus minus an MMF or an azathioprine. It's also associated with immunodeficiency syndromes like a CVID, HIV, or a post-transplant immune dysregulation, as Dr. Kapil has already told us about. And if that is the case, an IVIG replacement plus minus and macrolide is something that we would go ahead with. It's also associated with certain chronic infections, most common of which are atypical mycobacterias, mycoplasmas, or certain viral infections. And in that case, we would want to treat it with the antimicrobial or the antiviral therapy that it's associated with. And as far as the diagnosis using a cryo lung biopsy or a surgical lung biopsy is concerned, though the surgical lung biopsy still remains the gold standard, but we have emerging evidence and we also do that in our center routinely. A cryo lung biopsy now gives us an adequate amount of tissue and is helpful in making a diagnosis of bronchiolitis.
Yeah, thank you, Dr. Abhishek, for that clarity. Now I take the opinion from Dr. Varuna. Okay, Dr. Varuna. Okay,
Yes, sir.
yeah. Hi. So diffuse panbronchiolitis is often, under-recognized one. Yes, as a part of, overall bronchiolitis as well. But this is more often and it is very under-recognized. So what is its hallmark clinically, radiologically, and then therapeutic features? If you come across a patient with, DPB, how do you want to, manage, diagnose, manage both?
Yes, sir. Starting with the first point, talking about the clinical features, its presentation is around 230 to 60 years of age, mostly seen in non-smokers. Patient mostly have the symptoms of chronic productive cough with more of copious sputum, and there is history of dyspnea, exertional dyspnea, recurrent respiratory infections, and we get a classical of chronic sinusitis. So basically, there is chronic sinusitis, the chronic productive cough, and the nodules on radiologically, which are diffuse, is the clinical hallmark features. In advanced stage, the patient develop with the hypoxemia, corpulmonale, and talking about the functional and the spirometric presentation. Initially, we have the increased in the residual volume, that is air trapping, is seen. Later on, there is phases of decreased in the ratio of FE1, FEC, and the FE1 is reduced. And radiologically, there is classical diffuse centrilobular nodules and green bird appearance. Bronchial wall thickening is seen. And most importantly, that either the bilateral side is involved or the lower lobe is mostly involved. And last point which you asked, sir, is the therapeutic hallmark and the response which we see is with the macrolide. A low dose macrolide given is a good response and it confirms our diagnosis also. It has an
So,
immunomodulatory effect.
how low is the dose that you prefer, and then how long is the treatment recommended, Dr. Varuna?
The treatment recommended around for 6 months at least
Right.
with azithromycin 500 milligram OD.
Okay. So the other thing is probably we can reduce to, after initial probably 1 month, 2 months of, therapy, daily dose therapy, then probably we can reduce it to 500 mg thrice weekly, depending on the response is
Good.
really great. Probably we can cut down to even 250 mg thrice weekly. That's one thing. And then, but with macrolides, these patients, they do see, dramatic improvement. Thank you, Dr. Varuna, for excellent response. Now, Dr. Aishwarya, welcome back. And now I would love to ask you on respiratory bronchiolitis. Okay. When does it become clinically significant, and how should we approach? And then what are the various things that particularly in adult population we come across?
Yeah, I mean, if you look at usually bronchiolitis mostly associated with smokers. So as we all know, many smokers actually, for many years, their PFT would also be normal. So most of the bronchiolitis, especially with the smokers, it's usually in a very incidental finding. Like we do a BAL for a different purpose, and then we end up finding alveolar macrophages in them, and then we look at their CTs, and the CTs have we sometimes think this could be a HP kind of a picture also. So it's usually an accidental finding. And coming back to your question that, if the patient becomes symptomatic, then what are we really going to do? So how do we even, for example, now we see a lot of patients getting viral pneumonia, many viral patients getting into a bronchiolitis kind of a picture. So that starts happening if the patient is going, first thing is, I would say, if the patient is starting to develop wheeze, and the patient starting to develop progressive dyspnea, I would keep progressive dyspnea probably as the first symptom to look at, probably if this patient is going to develop a bronchiolitis. So the progressive dyspnea and wheeze that is not responsive to standard bronchodilatory regimens, then patient continues to be wheezing, continues to have breathing difficulty, and this breathing difficulty is going to be progressive. Probably the 6-minute walk test is going to be worsening. Second thing is, as ma'am was rightly mentioning about the CT findings. So the CT findings, usually it kind of starts like when it appears like a mosaic pattern, sometimes it's more like a viral GGO. But then this slowly starts developing into organizing pneumonia kind of a picture. And from then on, the CT starts showing like air trapping, and then pleural thickenings, and as ma'am said, this cotton bud appearance. It was actually new for me also. So more of, a more thicker mosaic attenuation, and that going into an organizing pneumonia kind of a pattern. So these are features that the HRCT would also support to say that this patient is having a bronchiolitis kind of a picture. And then going forward, if this patient continues to be, say, even in terms of a patient who has a viral pneumonia, persistently being on mechanical ventilator, not being able to wean off, we must have seen, I'm sure you're also seeing a lot of pediatric pulmonology cases. So a lot of children not being able to wean off ventilators, being stuck on ventilators, even with the protective mechanical ventilation settings. Then these are kids that are slowly going into bronchiolitis kind of a picture. But this is all acute. But if we are looking at smokers, then usually an incidental finding that then we follow these smokers up, in terms of seeing if they're developing into an RB-ILD kind of a picture. So we look at serial PFTs for them. Probably in transplants, is usually, as Dr. Kapil was saying, we usually look at every month to every once in 3 months after 2 years. And if it's a smoker that we're looking at with an RB-ILD kind of a picture on a CT, I would probably do a CT on him annually and do PFTs and DLCOs on him to start with, and then follow that up every 6 months.
But what is the center line of management of these patients apart from smoking cessation?
Yeah, apart from smoking cessation, I would say like we can give a steroid trial on these patients. So if we're looking at somebody where, again, if they are recently developed a bronchiolitis picture because of any kind of an acute illness, say it transplants, or say any recent infection that has caused them this, then I would look at getting that infection better. If there is any secondary infections from that, say if a viral caused a secondary bacterial, then I would start treating the secondary bacterial. Then if it is a GERD that's causing this, then start correcting the GERD that's caused. And on top of it, probably a low dose corticosteroids. I'm sure all of us have seen this pattern probably in COVID. I would actually, take COVID as actually a right example here. We would have seen that many patients kind of giving a bronchiolitis obliterans kind of a picture, those especially who were on ECMOs during COVID. We were a center who was running left, right, and center of ECMO. We had maximum ECMOs actually in Chennai, and most of our patients were weaned off ECMOs without transplantation. Were also people where we were actively treating them for infections, GERD control, and low dose steroids. And we also saw that few this organizing pneumonia kind of a bronchiolitis kind of turned back as well. So the only way where it gets stuck and we are not able to wean them off further are people where this bronchiolitis has developed a fibrosing kind of a picture as well.
Yeah, I'll come there. Once the fibrosing settles in, okay, it becomes a very, very difficult task for even survival. Probably you have to consider them for transplant. Okay, that's one thing. And second thing, so many people they believe that like smoking, even vaping can cause a similar problem. But my dear friends, for your understanding, vaping does also cause similar problem, but more amount of fibrosis is the predominant pathophysiology when the vaping induced lung injury occurs. Okay, and so that's why. So when vaping related lung injury we are handling, it is very likely a severe bronchiolitis, more of a constrictive pattern than anything else than RB-ILD. We need to remember that. And Kapil Bhai, okay, coming to you, in real world setting, how do you differentiate a proliferative bronchiolitis from constrictive bronchiolitis? As I was asking Abhishek as well, is there a definitive requirement of surgical lung biopsy, or do you get over with a bronchoscopy or bronchoscopic cryolung biopsy or conventional forceps lung biopsy? What is your take on this?
Okay, sir. So
and we have close to around 2,000 people watching. There are plenty of questions. Let's
I'll be very to the point, sir. I'll be very to the point. Between both of this, sir, constrictive and proliferative bronchiolitis, sir, as I mentioned before, there are certain differences before we even start thinking of biopsy. First is basically the meaning. Constrictive, as I mentioned, is an extraluminal sort of a scar around airway. Proliferative is an intraluminal thing. So it's almost like an intraluminal plug sort of thing. So that explanation is very important. Second, the presentation of these patients again is very important. When you talk about proliferative, it's more of a subacute sort of a presentation in weeks. Most probably seen in, let's say, cryptogenic organizing pneumonias or drug-induced. These are the settings. Whereas if you talk about constrictive bronchiolitis, it is an insidious sort of thing. I mentioned post-transplant. But apart from that, say all your connective tissue diseases, especially rheumatoid arthritis, it's more of an insidious. It will take months to develop. Third, before you jump to a biopsy, you need your hallmark PFTs. So every of our patient must undergo PFT. Your simple constrictive bronchiolitis will present with an obstructive abnormality. And remember, the small airway component will be so high that the RV-TLC or TLC ratio in these patients will be skyrocketed. The same will not be seen in proliferative cases. It's not necessary that they will present with an obstructive. They might have a mixed or sometimes even a mild restrictive pattern. And even reduced mild DLC are not necessarily a very increased RV-TLC ratio. CT pictures, when you do HRCT thorax with an expiratory scan, pure constrictive will have mosaic attenuation. So, these will worsen on the expiratory scan. But, just borrowing some things from what Dr. Kranti madam said, in cases of proliferative, it will not be like a clean sort of a CT, it's not only your mosaic pattern. It will, in fact, you will always have some sort of a patchy consolidations. And here, I'm not talking about the cotton one, which he said. It's more of your, tree in bud. It's a peribronchial sort of an opacities, ground glassing, centrilobular nodularity. So the CT in both really differs. And lastly, bronchoscopic picture. Again, as I mentioned, simple constrictive bronchiolitis, bronchoscopy will be clean. Of course, you'll have considerations because your patient will be very breathless. So your anesthesia and everything has to really be done very smartly. But that is not the case that you will see in proliferative, because, it will be more like an infectious sort of a picture, a lymphocytic rich ball. You are more likely to isolate, certain organisms as compared to let's say, obliterative bronchiolitis. Now,
Thank you so much.
your
Thank you so
question,
much.
sir. Okay, sir. Sorry.
Yeah. So now to Dr. Kranti ma'am, anything you want to add to this? And particularly when a patient presents with symptoms, we are suspecting bronchiolitis. So with a unexplained airflow limitation in the spirometry and a normal chest X-ray, what is your take?
Yeah, I think Dr. Varuna and Dr. Kapil have already enumerated the various points well. I'll just like to add that since the X-ray is normal, so we do not directly proceed to a CT because bronchiolitis will be one of our last differentials.
Yep.
So, but particularly when the patient is having a CTD, when we are not thinking about a classical CTD associated ILD, because the same reticular shadows could be there in both, and then we are thinking about various exposures, like it could be drugs, it could be viral infections, it could be any toxins, and we have already talked about transplant. So basically it is our clinical sense with the rest of the findings which will help us suspect this one of the rare etiologies.
Right.
Yeah.
But definitely we will end up in when something is not clear, a good quality HRCT with
Yes.
both inspiration and expression becomes a very, very mandatory in clinical practice.
And
to
expiratory
rule.
CTs are very, very helpful
Very
in our
important.
patients of bronchiolitis. Yeah.
Right. Excellent. Abhishek bhai, you want to add anything to the CT points, HRCT points? How do you say that a very good quality, high resolution CT is being taken in the given patient, so particularly when suspecting bronchiolitis?
So I think you and ma'am have already emphasized on this particular point, and I cannot emphasize on it any further, that an expiratory CT scan is absolutely mandatory if you need to diagnose bronchiolitis, because if you're not doing an expiratory CT scan, neither can you truly diagnose air trapping, nor can you recognize a mosaic attenuation, or can you differentiate it from a vascular cause. So an expiratory CT becomes mandatory in diagnosing a bronchiolitis, is something that I would want to say.
In addition to whatever all other panelists have mentioned very clearly, I would recommend each one of you not to look at the CT films alone. Try to look at the CT, a good quality CT in the packs. That gives more information. You can adjust the contrast. You can scroll it, and because in the CT films there is a limited cuts depending on the center where it is done will be given. But you need to see in the packs to get a better understanding of the CT. Coming to Varuna ma'am. Okay.
Yes, sir.
In connective tissue disease, what early indicators? Okay. See, not all connective tissue disease we suspect bronchiolitis. When do you suspect bronchiolitis, and then how to evaluate such patient?
Yeah, it's a tough thing to do to recognize these patients. So early indicators as per the history is important. There would be an exertional dyspnea that would be disproportionate to the spirometric findings. There would be patient complaining of persistent dry cough with no explained reason as per the spirometry. There would be an exercise limitation. The basic early indicators would be then. Then we will proceed further for the testing to look for this differential also. taking the PFT, the FE1, FVC not initially falls, but we have to see for the value of 25 by 75%, that would fall, and see the RV value, the residual volume, that would be increased as there is air trapping initially. And other test that can be done if we have an oscillometry, that is an important and sensitive test for detection of this. And there would be an increase in the R5 by R20 differences, and there will be the reactance area would be increased. And as all as mentioned, an important would be an HRCT, but an expiratory film to see
Right.
for mosaic attenuation, air trapping.
Thank you so much for that clarity. And anything, my dear friends, if you are handling connective tissue disease patients, is very, very important when there is a disproportionate symptoms. Okay. Yes, we often think, okay, ILD. We often think even pulmonary embolism. We often think pulmonary hypertension as additional points. But mind you, please keep bronchiolitis as also one of the differentials. And then unless we look for it, it is very, very difficult to identify and then treat it. And now I request Dr. Aishwarya to respond. Yes, you were answering this question in the last as well. But let me get a clarity from you, Dr. Aishwarya. Okay, can acute viral bronchiolitis in adults progress to chronic irreversible small airway disease, and what predicts the transition in very, very, straight 60 seconds for you?
Okay, so I mean, in adults, I would say if, say, a patient has had a viral pneumonia, and if this patient is stuck on a ventilator for at least more than 3 weeks time, or rather 15 days to 3 weeks time, then we are looking at and the CT showing an organizing pneumonia kind of a picture. Then we are looking at probably irreversible bronchiolitis kind of a picture here. And or say if the patient is even weaned off, and we're following this patient up on an OPD basis, if we're seeing a very early drop in PFT, as all of you just said, very disproportionate symptoms compared to the PFT, and wheeze which is not responsive, the patient continues to have a very bad dry cough, mostly nocturnal, and CT expiratory, as you all insisted, expiratory CT film showing air trapping and sometimes even fibrosis setting in. These are all signs that this patient's probably, unfortunately, a post-viral is getting into a irreversible bronchiolitis. I hope that was 60 seconds.
Yeah. Thank you. Thanks for that crisp answer. So, Dr. Kapil, yes, again going back to transplant centric question. In your practice, yes, you nailed multiple times in your talk, 3-4 times. I'm just also reiterating because very, very important. The early reasons why our transplant patient succumbs is not because of rejection, it's because of infections. So in your experience and what, as per evidence as well, how early you suspect BOS and how early you can detect in spirometry when compared to radiological findings?
Okay. Sir, even I keep it less than 60 seconds, sir. Like
Yep,
you
please.
mentioned. Sir, I have already mentioned this in my talk, but I would again
Yes.
like to mention this, sir. The average time which is seen in Western countries for the occurrence of BOS after lung transplantation is between 16 to 20 months. So you just consider it to be like 1.5 years.
Right.
However, that is the average. It is not
Right.
necessary. The youngest patient that I have seen who has developed BOS after lung transplantation is 3 months. So just
Right.
imagine you're expecting 1.5 years, but it can occur in 3 months, which is why the transplant pulmonologist has to have his antenna up throughout in the post-transplant period. You have to get their spirometry done at regular intervals. One more thing, remember in the early stages like BOS 0P and stage 1, the spirometry changes will predate the CT. So the CT changes will occur afterwards. And remember, it is not only one spirometry, but you need serial spirometries, which will persistently be changed. Only then do you diagnose this as BOS. So it's not only one, you need continuous spirometries to be done.
How many?
Sir, it can be a serial, sir. Once the thing starts decreasing, you think for reasons which can, give rise. For example, it can be GRD, it can be obesity, it can be all of this. You treat them first.
Simply, I'll tell you, okay, in my interstitial lung disease patient, what I do is, probably every 3 months, 4 months, upon review, I'll ask them when the patient is stable, a 6-minute walk test and a FVC to follow. But I'll ask them every week, every Sunday, mandatorily do a 6-minute walk test at home, how many steps they are doing, and then how much is the lowest saturation from their baseline. This is what I ask them to monitor at home. Okay. So can they do similarly the spirometry?
Yes, sir. So not the 6-minute walk distance. Yes, sir. Everyone is provided with a digital spirometer, and twice a day they are supposed to do these readings and send it to the transplant coordinator. So
twice a day.
Got these. Yes. So we have got these every single day.
That's what I need a specific answer. Twice a day, the spirometry is monitored. Thank you so much. And Dr. Kranti, okay.
Yes, sir.
So in clinical practice, okay, diffuse panbronchiolitis is not that rare disease, but again, how to differentiate from other chronic inflammatory small airway disorders in clinical practice?
Yeah, so I'll stick to that clinical part only. So panbronchiolitis, the classical finding which we see in these patients, I think Dr. Kapil has already 2-3 points he has already enumerated. Usually the Japanese East Asian population, non-smoking population, majorly in the non-smokers, the diffuse panbronchiolitis is there. And the typical book picture, that is the patient will complain of years of nasal symptoms like nasal discharge, post-nasal rhinitis. So chronic pansinusitis is one of the classical findings with quite a plenty of expectoration. So it has been mentioned that usually it is more than 50 ml per day for years and years together. So I have just sticked to that clinical part, and obviously for differentiating, then we have different investigations like spirometry and rest of the things, which I think we'll let go later on. Yeah.
Right. See, Abhishek, yes, this question probably appears repetition, but again, it is very, very clinical relevant. Mosaic attenuation anywhere in the CT, we cannot assume it is small airway disease, or there are some masquerades as well. And then what is its actual diagnostic value in bronchiolitis and the other differentials?
I'll be very quick, sir. So we need to understand that mosaic attenuation is a pattern and not a diagnosis, as you very rightly have pointed out. So it basically represents small airway obstruction in the form of air trapping coupled with vascular hypoperfusion. So it can only serve as a diagnostic modality when we also have expiratory air trapping, bronchial wall thickening, and centrilobular nodules, which combinedly suggest of bronchiolitis. And the masquerading diagnosis that we can have is something like a chronic thromboembolic disease, pulmonary hypertension, early hypersensitivity pneumonitis, and sometimes a suboptimal inspiratory scan can also give us a mosaic attenuation. So we cannot just jump to a diagnosis of bronchiolitis if we see a mosaic attenuation in a CT scan, and we need to take into the complete clinical radiological picture before coming to a diagnosis.
So quickly, okay, I'll ask you and then I'll switch over to Dr. Varuna. So whenever there is a need, okay, do you recommend a cryolung biopsy or surgical lung biopsy when it is very challenging? If the cryolung biopsy is still non-contributory, there are instances where for particularly bronchiolitis, to prove we need a very broad specimen like wedge lung biopsy kind of thing, Watts lung biopsy. What is your take on it?
So mostly, sir, it's a clinical radiological diagnosis, but as you have correctly pointed out, that if we are unable to reach a comprehensive diagnosis, biopsy is something which definitely helps. Initially, we used to send all our patients to Dr. Arvind Kumar, who works very closely with us in our center for a surgical lung biopsy. But as more and more data pours in, we started doing cryo lung biopsy as well, and we have very good thoracic pathologists in our team who come to a diagnosis of bronchiolitis with a cryo specimen. But yeah, then again, the gold standard still remains the surgical lung biopsy.
With associated morbidity for the procedure.
Absolutely.
Yeah. So over to further comments from Dr. Varuna on the same question.
Yes, sir. The TBLB has the limited reliability because of the sampling error. And though there is a negative result, but it does not rule out the disease always. I always emphasize diagnosis on the clinical, the physiological CT pattern, then as per the biopsy. And if we are suspecting in a post-transplant patient, then we can go for it and see for the rejection related changes are there. And surgical lung biopsy is the gold standard, but it all depend on the patient morbidity also.
Thank you. Thank you for that crisp answer, Dr. Varuna.
Thank you, sir.
Dr. Aishwarya, okay. Does bronchiolitis always manifest as an obstruction in pulmonary function testing? Is there any some patterns where you would come across? Dr. Kapil was mentioning earlier as well. But for a more clarity, so can sometimes you come across in restrictive pattern, or there is I have seen that apart from CLAD in post-transplant setting, there is something called RAS as well. That is restrictive allograft syndrome. So what is your comments on this, Dr. Aishwarya?
As you rightly said, yes, mostly bronchiolitis is an obstructive small airway disease, but there can be mixed pattern, there can be restrictive pattern. So mixed patterns can happen when there is a bit of parenchymal involvement, restrictive patterns when in case of RB-ILT kind of a picture or bronchiolitis obliterans syndrome kind of a picture. And as you just said, that mentioned that the RAS kind of a pattern, that is restrictive allograft syndrome. In fact, more than BOS, the restrictive allograft syndrome in transplant is really bad because the patient, we know that the patient is going to end up in a re-transplant only. Either a re-transplant or there's no U-turn from there. So in fact, more than the obstructive patterns on the PFT, if the patient tends to have a mixed pattern or if the patient tends to have a restrictive pattern, then the prognosis is actually bad. That's what we understand, because in these kind of a patient, it's where the parenchyma is involved and the fibrosis is already set in. So, and these are the kind of patients where just a PFT would not be enough. If we're following up on these patients, we as we all have spoken about now, that we follow up only with radiological findings as well as PFT with DLCO would play a major role in understanding what kind of a pattern this is and also to understand how the prognosis is going to go.
Yeah, thank you. And to Kapil, just sort of to clarify, so how do you see the in which settings do you expect either BOS or CLAD or RAS is going to happen in transplantation, in post-transplant?
Okay, sir.
What are the strongest? These the moment you see, my God, this patient is really in soup, and then these are the patients where that I need to have a very strong close follow.
Correct, sir. I will give you a very crisp answer of what exactly do we need to see. So in the post-transplant periods, the following things are really associated with an increased incidence of CLAD. First is any amount of rejection. As I mentioned before, it can be cellular rejection, it can be antibody-mediated rejections. Remember, cellular rejections have got classification. So an A2 or an A3 is obviously in ICU, but A2 variant of cellular rejection is very highly associated with developing rapid onset CLAD. Any amount of antibody-mediated rejection also will fasten the onset of CLAD. You've got something known as PGD, sir, which is known as primary graft dysfunction. Very simply put, it's something like an ischemia, sort of a reperfusion, sort of an injury, which occurs typically in the first 72 hours following lung transplantation. These are the patients who might need prolonged ECMO, and it's almost like an ARDS sort of a picture on the chest X-ray. It's unfortunately, even acutely, it's very difficult to manage, and even it has got a very high prediction for the appearance of BOS. Apart from that, infections, your simple respiratory variant infections, which probably you and me just shrug it off, but unfortunately for these patients, the more frequent infections that they have, they can herald BOS much more commonly. In certain patients, you've got colonizations, as I mentioned in my talk. So all your bronchiectasis, your CFs, and there are two organisms, sir, which is very important. One is Pseudomonas, the second is Aspergillus. And lastly, the bane of all respiratory diseases, especially post-transplant, is basically GRD. So your reflux causing microaspiration will fasten allograft dysfunction, and it has to aggressively be managed. And as I mentioned, sometimes post-transplant, we can subject these patients to fundoplications.
Fantastic. So that is more of addressing on a permanent basis, right?
Yes.
So now to Dr. Kranti, Kapil has touched upon post-viral bronchiolitis, and then some viral infections can lead to BOS as well. So when does and how does the early intervention alter the long-term outcomes in post-infectious bronchiolitis, Dr. Kranti?
Yeah, because over a period of time, the things can become irreversible. So the best window of opportunity, I think, is within first 2 to 4 weeks or up to a maximum of 6 weeks. So if we intervene early, it will definitely prevent the progression to an irreversible phase.
So probably in the modern era, I always contemplate, because I have seen patients being ventilated for ARDS. I have seen patients being ventilated on NAV, patients being managed with HFNC, patient being proning, and all these things. And then what I see is, when the criteria for a severe ARDS is meeting, it is not that we manage with whatever gadgets we have. That is the perfect time where we should take the entire control of the patient and convert into ECMO, and then let the lung heal, and then ensure nothing sort of this post-infectious bronchiolitis happen in this patient. A good comprehensive lung care is very, very essential in managing these post-viral infectious bronchiolitis patient. Add anything if you want to add, ma'am. Right.
Yeah.
And yeah, Abhishek, with increasing exposure to e-cigarettes and occupational inhalants, okay, are we underdiagnosing toxic bronchiolitis? And also some comments on current air pollution standards in North India.
The very short answer to this particular question would be yes, we are. So we have an emerging exposure of e-cigarettes, industrial solvents, flavoring agents, biomass smoke, textile and factory exposures to the least. And in the Indian context, we have a very, very poor habit of documenting occupational history. We have a very, very lack of small airway focused HRCT protocols. We have a very underutilized expiratory imaging protocols, and mostly in the periphery, these cases are being mislabeled as asthma or COPD. And as far as the air pollution levels are concerned, sir, now we have a very emerging subset of data of air pollution associated respiratory diseases, and bronchiolitis, toxic bronchiolitis particularly, is at the forefront. And this is being recognized as a separate entity. And as far as the cases are concerned, over the past couple of years, we have seen that as far as the change in climate is concerned, whenever the winter comes and there's a rise in the AQI levels, we see more and more cases of these patients who come into our OPD seeking treatment. So it's very important to recognize them and treat them accordingly.
No, I was wondering when I was going through the literature, even the pollutants like sulfur dioxide, nitrogen dioxide, and then some common chemicals that we come across like formaldehyde, acetaldehyde, acrolein. These are all the very common day-to-day. We may be also getting exposed, okay, significantly. These are the things which are causing toxic bronchiolitis. My dear friends, please be aware, have a suspicion. Without suspicion, we cannot diagnose. Dr. Varuna, let me ask you, among RA patients, other CTD patients, which carries the most aggressive bronchial phenotype and why? Okay, and RA, Sjogren, SLE, and systemic sclerosis.
The RA is basically which causes an aggressive bronchial phenotype because it produces a constrictive bronchiolitis, and
Right.
it is due to the autoimmune inflammation which goes on. And if we see the spirometry, there is then leading to the fixed, progressive, and airflow limitation is there with poor reversibility. So it's
Right.
a RA which is the aggressive form.
Thank you, Dr. Varuna. There are numerous questions which we need to answer. Of course, we are running short of time as well. Really, I thank Dr. Santosh, Dr. Janvi, Dr. Mansi, Dr. Mohini, Dr. Pankaj, Dr. Varun, Dr. Madhav, Dr. Pankti from Nasik, and then Dr. Ria from Nasik, Dr. Komal from Delhi, and a lot of appreciation, tons and tons of appreciation message that is pouring in. And then Dr. Namrata from Mumbai, Dr. Darshan from Ahmedabad. Okay, we'll take, if it is not covered, definitely we'll take. And let me ask Dr. Aishwarya about, Dr. Kapil earlier commented about, some points about GERD and then bronchiolitis. Can you please quickly comment, how do you see GERD and aspirations, micro or macro aspirations, and how to manage them in clinical practice?
So I'll tell this from my learning, sir.
Yeah.
So both my trainings from both Toronto Lung Transplant Program and Vienna Lung Transplant Program, they both took the gastric reflex as a very, very serious complications. We used to have MDTs, like we as fellows should present cases on HLAs and rejections, but we also had a GI week, which used to happen once in 3 weeks. So those complications were taken so seriously because they keep churning out papers based on GERD associated BOS clad. So it is a major complication for lung transplantation patients. So if a recipient, especially if a recipient has a systemic sclerosis, we all know that the patient is going to have a very bad reflex. And they have sometimes even rejected such patients if the patient has a very bad systemic sclerosis, very bad GI disorders. So both the transplantation program had these protocols. So they used to do gastric emptying, esophageal manometry, and pH metry. These three will have to be a part of the pre-transplant workup. So if these three are bad to an extent that, say, medically not being able to be corrected, they have done pre-transplantation fundoplication also. And if these patients especially fall into systemic sclerosis criteria, they've done fundoplication on these patients. And especially on post-transplantation, as Dr. Kapil was saying, it can happen even as early as 3 months. So if a clad is going to happen at as early as 3 months, most likely, if you would see, not just in the West, even here, even I take it seriously here, all my pre-transplant patients will have these 3 GI studies done, though it's cost involved, because it does play a huge role on patients developing bronchiolitis. And these patients will have to be put on PPIs, very, very strong PPIs pre and post transplantation, or any patient with bronchiolitis, I would say, even if you're not looking at a transplant patient here or a regular pulmonology patient, this patient should be on a strong PPIs. And if you're looking at GERD as a cause of bronchiolitis, then I would say even fundoplication can be considered on these patients, because constant at as early as 3 months, like they used to follow these patients as rejection biopsies every 3, 6, and 12 months. They also used to do GI studies on these patients, no matter if they know that, not just if the patient has GERD, just as a prophylactic measure, all these patients would have a pH metry and esophageal manometry done at 3, 6, and 12 months. I agree that cannot be done in our settings because of cost involved, but those 2 centers used to do this both pre and post, at least for 1 year, to follow up to prevent BOS in patients post lung transplantation. So that's how much important is GERD causing bronchiolitis.
So my quick understanding, apart from whatever you have said, is it is not that about only strong PPIs. We need to add a prokinetic agents as well, so that the gastric emptying can be enhanced. Otherwise, the reflex remains probably, if we don't address the gastric emptying time, delay, it will become a major catastrophe. That's another important point.
Lung transplantation, sir, most patients have vagus nerve disorder, because mostly 80 to 90% the vagus nerve is knocked off. So most of these patients have GERDs or esophageal motility disorders. So that contributes to having BOS.
Right. Thank you. And Kapil, quickly, what is you were mentioning about fluticasone, agitral, and azithromycin, and then Montelukast FAM therapy in BOS? And then when do you escalate to higher therapies? Yes, you mentioned about irradiation measures and then extracorporeal photopheresis measures, kind of thing. Quick comments?
So, sir, FAM, as you mentioned, it stands for fluticasone, azithromycin, and Montelukast. So there was a concept that the combination of these 3 was used in post-hematopoietic stem cell transplant, which led to bronchiolitis obliterans, showing a decent response. So what they did is they tried to just cut, copy, paste, and use it after lung transplantation. But sir, out of the three, my step personally would be azithromycin number 1, followed by montelukast, followed by fluticasone. Azithromycin is the most studied immunomodulator basically in these patients, which has got somewhat of an effect, especially in neutrophilic predominant, your bowel samples. They have done multiple dosages of azithromycin, but the one which works the best is 250 thrice a week. Montelukast 10 milligram dose, but however, the recommendation is very, very poor. And fluticasone, also like montelukast, unfortunately, the recommendation is very poor. So my personal thing is I use azithromycin number 1, followed by montelukast. I personally do not use fluticasone in my patients. Now, the second part of the question, sir, you asked me about ECP. When should we consider? Again, sir, I'm telling you, in India, unfortunately, there is only one center which is doing ECP. In the West, it is more easily available and the cost is covered by, your insurances and your programs and everything. So in our country, unfortunately, it's very difficult. But theoretically, sir, every program will have a difference in when to do it. If you ask me personally, sir, I would like to get everything in order, get azithromycin, get montelukast, but the time that my patient goes from BOSS 1 to 2 is the time when I'll start considering that this patient needs ECP and I'll start counseling. Remember, sir, in ECP, there are a lot of changes which we as transplant pulmonologists need to do. It has to be done under antibiotic cover. Your second immunosuppression, which is either MMF or azathioprine, has to be stopped before the patient undergoes ECP. And third, you also need to give an antifungal cover. Remember, antifungals will have drug interactions with tacrolimus. So all of these need to be considered when the patient is going for extracorporeal photophoresis, which ultimately damages the lymphocytes so that the immune reaction, the alloimmune reaction towards the allograft decreases.
Fantastic explanation, man. Thank you so much. Dr. Kranti, so here is a question for you. Someone asking, Dr. Mohan is asking about what is the mechanism by which macrolides work in diffuse panbronchiolitis so dramatically.
Yeah, so it is based, So macrolides primarily because of the immunomodulatory effects. So that is basically the reason for panbronchiolitis. And I think I like to enumerate here the other places or the different types of bronchiolitis where macrolides will help. So apart from panbronchiolitis, I think Dr. Kapil has already told us about the CLAD. So definitely macrolides are not that effective in CLAD in comparison when we see the head-to-head comparison with the panbronchiolitis. But in a subset of CLAD patients, that is the neutrophilic reversible CLAD patient, the allograft dysfunction patients, where there is approximately 15% of neutrophils in the bowel fluid and there is a rapid decline in FEV1. This is how we differentiate that subset of CLAD patients. In that particular subgroup of CLAD patients, I think macrolides are quite helpful. And when we talk about the Indian context, there is one very good expert recommendations by Dr. Rajadharan group on the use of macrolides in different respiratory diseases. So they have specifically highlighted that macrolides are effective in Indian population. It is primarily the bronchiolitis obliterans which is most common. So macrolides are not going to help in that subgroup of patients in the Indian subcontinent. So one is acute bronchiolitis, second is CLAD, particularly the subset which is neutrophilic reversible, and third is obviously the the first is practically the panbronchiolitis.
Yeah. So some medical emergency, Dr. Abhishek has to leave. So final comments from you, Dr. Abhishek. Anything you want to add? Whatever your contribution is immensely appreciated. And then very great points you have commented all through the webinar. Any final comments before you leave?
No, first of all, I'm really very sorry that I have to leave.
No problem. You said it is an emergency. Emergency patient comes first. Don't worry.
Absolutely. Fantastic discussion, sir. Just one point, and that is it. Bronchiolitis is something which is very underdiagnosed. We need to have a very, very strong set of prehind, if I may say, to diagnose this. And once diagnosed, we need to phenotype it correctly. Once we do that, we need to correctly manage it, treat it. And once we do that, I think we'll be able to help our patients immensely.
Fantastic. Right. I'll continue to another 10 minutes and then close it. See you
Thank you.
again. Thanks for participation, Abhishek. And Varuna, ma'am.
Yes.
Okay. So how about managing constrictive bronchiolitis in CTD-associated patient? What does the role of immunosuppressive therapy in across the spectrum of CTDs?
This basically we have to understand there are two phases. That first is the early phase, that where is the inflammation has started and is potentially a reversible phase. And second is the late phase where there is a fixed concentric fibrosis, luminal obstruction is there, and it will be a phase that is irreversible. So initial phase of early phase where the immunosuppressants can work. But like in patients with the RA, we have talked about that there is an progressive air obstruction is there, and like in systemic sclerosis where there is not of much role, but in Sjogren's, if we start in the initial phase there can be a help, and later on as the progress is there is like in fixed obstruction there is not of much response of immunosuppressants.
Thank you, Dr. Varuna. To Aishwarya, okay, if you had to identify one major clinical error in the management of bronchiolitis in India, what would it be? What
So I
are your
think
inputs?
a couple of errors that we're actually
Yep.
seeing. One is
Please.
probably treating every viral with an antibiotic and just constantly suppressing symptoms. One, two, unnecessary resistance is being created. And we all know that bronchiolitis obliterans, a small dose of steroids could cause a bit of a difference before they hit in the phase of early fibrosis. But as we all seen what happened during COVID, overuse of steroids, that itself caused multiple secondary infection, worsened the BOS or RAS than it could, than earlier than it could come. And third is maybe like all of us have just discussed that sometimes the PFT is not matching with the patient symptoms, and sometimes the patient symptoms is not matching with the PFT. So I think technically, along with the PFT, all of us should monitor the patient's hypoxic status, patient's 6-minute walk test regularly, and we all should have a structured protocol on how frequently are we going to do the PFTs, CTs, and probably the 6-minute walk test. You were saying like if the patient is unable to do a PFT, probably just do a 6-minute walk test. Like for most of our transplant patients, we just give them a peak flow and tell them to send a peak flow report every day, something like that, some regular monitoring. And of course, in every forum we all come across, we all discuss only papers from the West. We need more clinical trials from India on these topics as well, and more such academic discussions, such high impact discussions on such topics frequently.
Thank you, Aishwarya, for that clarity. And then quickly, any webinar, if we don't address the audience questions, okay, it is incomplete. Let me quickly go through. Dr. Shahbaz Sawant is commented that what HRCT differentiates bronchiolitis from early ILD. We mentioned, we discussed that. Dr. Sanket Gadam is what differentiates bronchiolitis from viral pneumonia clinically. Again, we discussed. Will come out, ICS soon will come out with radiological patterns as a separate and then investigations patterns in bronchiolitis with a separate webinar. I'm promising on behalf of Dr. Amita Nene. Mehak Agarwal, can it be prevented? Any specific precautions for targeted group? We discussed Dr. Mehak. And Sanket, how do you differentiate bronchiolitis from early asthma? We discussed. And lot of appreciation messages for the content we delivered past one and a half hour. And describe the seasonal variation of bronchiolitis in India. Dr. Atif Patel, I don't know, to be honest, but again, probably as all respiratory illnesses are pretty common in winters, probably winters may have more amount of bronchiolitis. I'm not sure about that. Can there only be cough without breathlessness, and can bronchiolitis be only presentation in rheumatoid arthritis exacerbation without joint pain? Dr. Radha Munja, thank you, Radha ma'am. I call Radha ma'am as a Radha Didi. So sweet of you for that perfect question. You know the answer, I know that. Okay, yes, cough without breathlessness can can also be the predominant symptom without any joint pains. Okay, and Dr. Mansi commented, very informative session. How do you manage bronchiolitis with ARDS? Dr. Namrata from Mumbai asked. We discussed, Dr. Namrata, about this. Dr. Darshan is asking us, explain the mechanism of air trapping. Yes, Kapil, quickly, you want to comment about the mechanism of air trapping? Or anyone? Dr. Kranti?
Yeah, obviously it is the small and the bronchiole. So there is air trapping. So that is basically causing that
Right.
hyperinflation and
So,
everything. Yeah.
Dr.
Peripheral
Darshan,
involvement.
very clearly what happens is, in bronchi and then bronchioles, the major difference is these bronchioles doesn't have any cartilage. Once they are plugged with a lot of inflammatory material, either within the lumen or from the outside the lumen, what will happen is there is a one-way, okay, inhalation will be smooth, but exhalation, because they don't have a cartilage, they get collapsed and then a lot of air gets trapped. That is the mechanism. And what is the mechanism of apnea in bronchiolitis? I don't know, Dr. Kamal. Okay. And
I
then,
think
but
apnea is hardly known in bronchiolitis. Like
yes,
I could not find any literature on apnea
right.
in
Yeah,
bronchiolitis.
it's more common in COPD, but small
Yeah.
airway disease there's not much correlation.
Yes.
And how does, but I can say that a lot of apnea patients may have significant reflex problems.
Yes.
That can contribute to some amount of, bronchiolitis. I don't know really whether what the data exists or not. How does GERD contribute to BOS? We discussed in detail. Kapil has mastered it. And then what infections are most associated with BOS development?
Come in over here, it wasn't me, sir. It was Aishwarya who answered that very well. How does GERD contribute to BOS?
Yeah, what is significance of airway colonization? We discussed, Dr. Madhav from Gujarat, and how can BOS be differentiated from restrictive allograft syndrome? Dr. Varun, we discussed, and Dr. Pankaj, what is the role of azithromycin? We discussed. Dr. Mohini from Nashik, why can a patient with severe bronchiolitis have a completely normal chest X-ray? Any quick comments, Dr. Kranti?
So can you please repeat the question?
Why can a patient with severe bronchiolitis can have a completely normal X-ray?
That we have, I think, already discussed. There are certain
Discussed,
things
right.
which can only be found in on HRCTs, particularly the
True.
expiratory films, no?
Right. And what general preventive measures reduce transmission of RSV in hospital settings? Dr. Santosh, it is a airborne
Or infection
spread.
control measures,
For
all the
infection
eyes.
control, air mask, masking and all.
That's
Yeah.
important. How does small airway fibrosis differ from emphysematous destruction? Dr. Vikas, anyone wants to take? And how does, we discussed, of course, that how does exercise intolerance manifest in patients with BO? Is pulmonary hypertension a recognized complication of long-standing BO? Anyone? Dr. Varuna wants to comment. Dr.
Yes.
asking, is pulmonary hypertension a recognized complication of long-standing BO?
Yes, sir. The
Yes, sir, that
mechanism
can
will be
happen
same as your airway
because of
disease only.
chronic,
So all your chronic airway diseases always will present with pulmonary hypertension. Same even long-standing obliterative bronchiolitis will present with pulmonary hypertension. It is a recognized
Long standing, it happens.
Right.
And about the exercise intolerance, I think 6-minute walk test is one of the tests which could be used to find out the early changes.
We briefly touched upon that as well.
Yeah.
What are the indications for oxygen therapy in bronchiolitis obliterans? Dr. Chandrasekhar, wonderful question. It's again standards of practice. Ensure that the PO2 doesn't fall less than 59.
Yes.
But again, as a surrogate marker, saturation should be always kept more than 90. And then what is the role of the commonest mistake again what clinicians assume is a resting saturation of 90. They assume that exertional saturation will also be as a 90. Please do not evaluate like that. Even when exertion, how low the oxygen is going down, okay, you have to monitor and then ensure that similar amount of oxygen support have to be given to keep always the saturations above 90. And what is the role of systemic versus inhaled corticosteroids in BO? We discussed Dr. Akanksha. What preventive strategies we discussed? How early removal from exposure alter disease course in inhalation BO? We fairly covered. lung transplantation related, Dr. Samarth. Okay, let me ask Dr. Aishwarya quickly. Consider this for severe BO unrelated to transplant. I'm not sure about this question. Kapil, when should lung transplantation be considered for
Sir,
severe...
ideally, sir, lung transplantation for every respiratory pathologies have got a very specific referral and a listing criteria. So in
Yes.
here, what he means is there is a
ISHLT
small airway
guidelines.
disease. So you'll consider this to be an airway disease and it comes under COPD category, which has got very specific criteria on when it needs to be referred, when it needs to be
Agreed.
listed. For
Transplanted.
example, an FE1 of let's say 25%, they need to refer. A board index of 5 to 6, they need to refer. Chronic hypercapnia, they need to refer. And in terms of
6-minute walk
listing,
distance of less than 250.
correct.
Right.
And if the desaturation is, goes below 88, and even listing criteria, as Dr. Aishwarya will also agree with me, is again very crystal clear given in our guidelines. For that, you need a minimum of board index of 7, and then you need further worsening of this patient.
Right.
All they have to do is follow the ISHLT guidelines for referral and transplantation protocols. It's all clear there. Indications
So
to
there is
when to
more number of questions coming up. I think it's time for us to wrap up. I'll take one-liner take-homes from each one of you. Kapil.
Sir, bronchiolitis is very commonly seen by all pulmonologists, unfortunately underdiagnosed and ignored. Thanks to this seminar, I hope that it is given the importance which it deserves.
Dr. Kranti.
Try to find out the cause as far as possible so that we can treat our patients properly. So we should not directly rely on macrolides or on corticosteroids as far as we can identify the cause, because majority of the causes are secondary. So I think we will be better off with it.
Dr. Varuna.
Radiological importance is also there in order for an expiratory scan, which has not been done on the routine basis to rule out the bronchiolitis.
Thank you, Dr. Aishwarya.
I just feel it's a very underrated term in our field of pulmonology, sir. Now this discussion has actually brought a lot of insight to all of us, I feel. I mean, I saw a question as well. One person said, are we treating all bronchiolitis as unresponsive asthma? Probably. So I feel more guidelines and discussions will help all of us diagnose it earlier, because a lot of it is reversible.
All great things comes to an end. So, but ICS promises you, okay, soon we'll do bronchiolitis question 2 as well. Okay, and thank you. Close to around 1800, 1900 logins, and then your active participation means a lot. Thank you, Lupin, for unconditional support for ICS webinars. And again, my job was made super easy with star-studded panel. Okay, thank you, Kapil. Thank you, Kranti ma'am. Thank you, Dr. Varuna. Thank you, Aishwarya. And of course, Abhishek just left for a medical emergency to attend. And in my words, bronchiolitis is a spectrum, both inflammatory and fibrotic distinctions. Okay, we need to see. Expiratory HRCT is very, very important. And constrictive bronchiolitis is patchy and often biopsy negative. Post-infectious and autoimmunity allergies are frequent but under-recognized. Transplant settings, early FEV1 decline, please hit it hard and hit it fast. Diffuse panbronchiolitis, response wonderful to the macrolides. Toxic inhalational injury, very critical, and then ensure that you manage early. GERD and aspirations are constant nuisance in managing all these respiratory issues. More importantly, bronchiolitis. Many cases are irreversible. Early detection becomes very, 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 very crucial. And profusely thank Dr. Amita Nene and team for giving us a wonderful opportunity to spread the information, most vital content, okay, which is most neglected. Honestly, it is not covered in any webinar across India. Okay, thanks, Dr. Amita Nene, for this wonderful opportunity. Good night. See you next week.
So thank you so much everyone for insightful knowledge and valuable time. So with that, we are closing this link. Thank you.
Are we offline?
Yes.
Thank you.
Garo, sixer.
Hey, come on.